Well, good morning, everybody. I think we will get started here. Welcome. So we are here with part 2 of our end of life series. Today is preparing for a good end. We had part 1 yesterday. Some of you folks may have joined us yesterday, and so we thank you for that. And today there will be a little bit of overlap of some of the information that we talked about yesterday, but also lots of new and good information. My name is Jean Alton, and I'm a senior dementia educator at Alzheimer's San Diego. And I'm happy to be co-presenting today with my colleague, Amy Abrams, who actually is the director of education at Alzheimer's San Diego. Amy?
Good morning, everyone. Glad to be here. Thanks, Jean.
And we also have with us here today a couple of other colleagues who will be assisting us. And one of those is Ellen Boucher. Ellen, are you here? Do you want to come on camera?
Good morning and welcome, everyone.
Thanks, Ellen. Ellen's going to be providing our clinical services support today. So we'll tell you how you can reach out to Ellen and how she can help you today and help all of us today. So, and then additionally, we have Lindsay with us today. Lindsay, do you want to just peek in and say hello?
Hi, everybody. I'm here to help with any tech requests you might have if you're having any issues with your camera, your microphone, or anything like that.
Here's our agenda for today. We've got a lot of different things to talk about. And so we're just going to jump into it here. And what we are really doing here is focusing on the end stage of dementia and all the kind of pieces and parts that are important and can be supports to both the person who is in the end stage as well as the care partners and family members. Some of these supports will happen really at the end stage, but some of them need to happen ahead of time and for you to be aware of long before the end stage comes along. So that's what we're wanting to do here today, is talk about all of these different things so that you can be thinking about it. Hopefully have already maybe done some thinking about it and some planning, but we want to give you some more of those tools for you to be able to do what we are calling preparing for a good end. And so with that, let's just talk about the end stage of dementia just a little bit here. And let's just start by taking a moment and just take a deep breath, everyone. Deep breath in. What I am encouraging you to do is what I am doing right now. Just look at this slide of the water. Look at the reflection on it. And see the movement. Maybe imagine being in the water. It's a comfortable temperature, but you're floating there. Just to be for a moment. Let whatever it is that you're feeling here today wash over you. Feel it, let it run through you. And if you would take a moment, if you like, send us a chat and tell us, what are you feeling right now? Feeling maybe a little anxiety about talking about these difficult subjects, maybe a little fear. Maybe you feel calm and ready for this discussion. Share with us a little bit about what you are feeling. that we're talking about here today, folks. Somebody is saying they feel grateful, drained. All sorts of different feelings and experiences that we have when we talk about end of life. And when we talk about planning and preparing for the end of life. Sadness, seeking peace, exhausted. Okay, well, it's important for us to be in touch with all of those feelings. And so let's join together here and talk about how we can prepare for a good ending. I'm going to talk about some of the language that we use with regards to the end of life. And some of the language can be complex and complicated. Sometimes I think the language, we throw it around a little bit and without really kind of thinking what is behind the language. Yes, it's a chronic disease or an acute illness. It's complex illness, it's serious. It's a life-limiting illness or a terminal illness. What we're talking about is death. Dementia is fatal. People can die with dementia, but they can also die from dementia. And those things are not mutually exclusive. So it's important for us to have a good understanding that dementia is fatal and to talk a little bit about what end of life looks like and how to prepare for it. So let's start with how do we plan and prepare for the end stage of dementia. A lot of that planning needs to come much earlier on in life. And really, this is true for all of us, whether we're talking dementia or anything, any other kind of illness or accident or situation that may come up. With dementia, however, what we know to be true is that it is a fairly long and slow progression over time. And so as you see in the slide here, the blue wavy line is showing function over the course of time, starting at a higher functioning level early on in the disease process, and then moving to the middle and moderate stages, and then later on towards the end stage, where the functioning part is really down to a very low level. So it's long and slow over time. That's the usual expectation with dementia. And time-wise, what the statistics show us is it could be anywhere from 2 to 20 years from time of diagnosis to end stage. And so that's a wide variation of numbers, right? From 2 years to 20 years. And I feel like I can put myself in your heads, in your minds, and say, well, what is it going to be like for my person? Is it 5 years, 7 years, 10 years, 15 years? And the fact is that there is great variability. And the reason being is that every person with dementia is unique. And so they may have other health conditions going on. They may not have other health conditions going on. There's just so many different factors that play into how things are going to progress and the speed of progression. But generally speaking, when we're talking about end stage people in the end stage of dementia, that we are talking about a tremendous loss of functioning and really becoming dependent on others for all aspects of daily living. So we talked about this yesterday, and we'll just briefly mention it here today as well too, that when we are talking about the end stage, this is when we are seeing the damage from the dementia is affecting these parts of the brain, the cerebellum and the brain stem. And so I want you to try and tie this in to what I have just mentioned about the tremendous decline in functioning of people living with dementia in the end stage. So the cerebellum is being damaged, so we see motor skill and muscle control being impacted. We see speech being impacted, meaning likely to be much less speech, if any at all. The brainstem governs the swallowing, the body temperature, digestion, food, our sleep cycles, and our heart and lung function. So again, in the end stage, we're seeing these areas of function being impacted. More problems swallowing. The body's less able to control and manage body temperature. Digestion slows right down. We may see less bowel movements and less urination. We see changes in the sleep cycles. We start to see changes in the heart and lung function as well too. See changes in how people are breathing. And there may be more changes going on in not only how the heart is actually working, but also in its rhythm. So there's some losses going on, some changes in functioning that are losses. But it's important to also remain aware of and attuned to all that remains in people in the end stage of dementia. And there is much that remains, folks. I can attest to that. And oftentimes what remains is the sense of people and place. And let me just add to that history as well too. I spoke to this yesterday, that to be a person who is important to the person with dementia in the end stage, to be somebody who has loved the person and been loved back, had some importance in their lives, gives you this rich history with your person with dementia. And so that's more than just the sense of people and place that you can be sharing and are sharing with your person with dementia. It's those memories, your history together, your lives, how they've intertwined, and all the different things you have done together. And people in the late stage can respond to sounds, touch, and tone, and really can respond to and experience lots of nonverbal sensory stimulation. I believe this truly. I feel I have seen it with clients that I have worked with, but also with family members. And so even though we may not necessarily get responses back from our people who are in the end stage, I think it's important for us to be aware that that doesn't mean that they're not receiving that information and being comforted by it. So keep all those things in mind. Do we stay connected and through to the end? All sorts of different ways. We talked about a little bit of this yesterday, but it is, I think, important to manage our expectations. And I think really your expectations should be none. Just go in with an open mind and an open heart. With short visits and use their name and or, we say versus terms of endearment, unless that's been a practice of yours with this particular person over time. But use their name to connect with them so that they know that you are speaking to them, not to perhaps somebody else in the room. Remember that there is a shutting down of the functioning, many areas of the functioning. So we may need to be specific in addressing. Mom, maybe I say, Mom, it's Jean, your daughter, I'm here. That's just giving information about who I am to Mom, and then to go on from there. Allow for that silence and those closed eyes with no necessarily response. Look at using music and engaging other senses, and then just be attuned to the minor responses. Be ready to try something else, and don't be discouraged or dismayed if you feel like you're not getting any sense that your person is responding to you or has heard you. Trust that they have and carry on from there. At the end of life, there may be little or no mobility, and people do tend to be spending more time sleeping than awake. Communication often becomes very little, if any at all. And again, people are often minimally responsive. So go with what you can, hold hands. I mentioned yesterday with my father-in-law, when he was dying, we would hold hands, and our little signal with each other was 3 squeezes, 1, 2, 3. And that meant, I love you. And so I would squeeze his hand, I love you. And then I would get that back. We didn't say a word to each other. That's all we did. You may have no intake of food or liquids, or people not just not intaking it, but refusing it, turning their mouth away. Hold hands and feet, because the blood flow is not going so much to the extremities. And we may get what I referred to yesterday as mottling in skin color, which means it starts to get blotchy looking, mottly looking. And again, we will see those changes in breathing. So recognize grief, folks, and it's not something that we experience only after somebody is gone. Yesterday, together with Rebecca, she explained very nicely about ambiguous grief and loss, where we're starting to grieve the person even though they have not died, that they are still with us, but we're starting to go through the grieving process. So let it wash over you as it needs to. There's no right or wrong way to experience and feel and manage grief. Have a life preserver of some kind as you're floating in this water, because we all need that at some point. What does that life preserver look like? Natural supports through family and friends, Alzheimer San Diego, hospice, palliative care. There's all sorts of different supports that you can build into your plans and preparations for a good end, for your person with dementia and for yourself. So we're going to talk a little bit further about some of these supports. So Amy, I think that you may be up.
I am. Can I take the remote control, please? We'll see if it works.
Good to you. There you go.
Great. Thank you. I think that's going to work. And if not, I'll let you know. So thank you, Jean, for introducing the important topics, what to expect at the end of life. And here in these next couple of segments, what I'm going to be talking about are those life preservers that Jean was just talking about. Don't want to be floating around in this ocean alone. There is support, and palliative care and hospice care in particular are two resources we want to make sure you know about. They're not for everybody. They're not for every situation, but they are underutilized. And so our goal here today is to help you understand what they are, but also what they aren't, and let you know that this support is available, help you figure out how to reach out for more of that. So let's see. Okay. So palliative care and hospice care overlap in some important ways. I just want to bring your attention to the text in the middle of this circle here in this image, if you're able to see that on screen. I'll go through in some detail here what palliative care is, what hospice care is, but what they both are is comfort care. The goal is to reduce stress, to reduce suffering, to offer complex symptom relief related to a serious illness. Jean talked about some of the language of end of life, serious illness versus terminal illness. For our purposes here today, doesn't matter. Right? We're talking about life-limiting illness of any kind, including late-stage dementia. And palliative and hospice services both provide not only physical comfort and relief, but also very important psychosocial support as well. So let me start by diving in a little bit on the details of what palliative care is. I'm using the words care and services interchangeably. There's no real distinction, just for clarity there. So palliative care is medical care, and it's medical care that focuses specifically on alleviating suffering, to put it broadly. By suffering, we mean physical pain, we mean the symptoms of serious illness, the emotional strain and stress of living with serious illness. All of those fall into the category of suffering that palliative services are designed to address. So palliative care is usually medical in nature. It's about the administration of medications or other therapies. Sometimes things like radiation can be administered to shrink a tumor that is causing pain. Right? It's not necessarily curative. It is designed to address the pain, the symptoms related to the illness. So palliative care is medications and other therapies that are generally used along with curative care. So if a person is living with a life-limiting illness and they are still seeking treatment or cure, even palliative care services can still be used. You can think of it as pain management, pain relief. Palliative care is appropriate at any stage of a disease. If there's pain, if there's suffering of either a physical, spiritual, or emotional nature, palliative care is appropriate. Any stage of a serious illness, not just the late stages or the end stages. So regardless of whether or not the illness is in fact life-limiting, if there's a limited life expectancy or a particular prognosis, doesn't matter. Everybody who's experiencing pain is eligible really for palliative care. It is not time limited. It can be used on an ongoing basis, and palliative care services can be used anywhere, not just in hospitals, for example. For many people, palliative care services are initiated while they are in the hospital, but that is just a matter of circumstances for most of us. It is not a requirement. They can be used by people who live at home in any setting. Okay. So what exactly are palliative care services? First, let me start by just saying they are not any one specific thing. It usually involves the support of what we call an interdisciplinary team. Lots of different professionals are involved. Palliative care services are prescribed by and initiated by a physician. Either a hospitalist, a primary care physician can make that referral, and then they are administered. There is an MD that is overseeing the palliative care that is being provided. So there's always a physician involved, and then there are nurses, social work services for resources and support, chaplaincy services for those who are seeking relief from spiritual pain or seeking religious or spiritual support. And then there are also, depending upon the program and depending upon the nature of the person's illness or pain, there are also some supplemental volunteer services that can be brought in. I'm thinking of things like music therapy services and other types of non-medical palliative care. So that's who is providing the palliative care services and what are they doing. So there's pain and symptom management. Again, this is usually what we're talking about is the administration of pain alleviating medication, but there are other therapies that may be used to address a person's symptoms. There are in-person visits to the home or wherever the person calls home, whatever that facility, institution, community, or private home may look like. There are in-person visits to administer care, and there's also telephonic support. So people can visit a doctor at their office, or palliative care services can be provided at home in some circumstances. So the palliative care team, that interdisciplinary team that I described a moment ago, is there to support the patient and their advocates in navigating all of their treatment options, not just the palliative care, but medical care, other types of support and resources that might benefit the person and their support system. Advanced care planning services are provided as a part of palliative care services in many cases, making sure that things like advanced healthcare directives are created or current, that there are things like POLST forms in place, the physician's orders for life-sustaining treatment. Jean will be talking about some of these documents and advanced care planning processes in a little bit here later this morning. And then of course, referral out to other community resources as needed. How is palliative care paid for? A common question and a good one. Generally, if a person is a Medicare recipient, it is fully covered by Medicare Part B, but of course, subject to any co-payments that your particular Medicare plan or supplement requires. Is it covered by Medicaid? Yes, and it depends on where you are. In California here, Medi-Cal does cover palliative services in many cases, and most private types of health insurance also cover palliative care as well. Again, think of it as pain management, right? So most insurances are going to cover that, but as with any other type of medical care, it is subject to any supplemental or co-payments that might be required. So every payer, Medicare or Medicaid, private insurances is a little bit different in what they cover and what they don't. Some specific medications or treatments may be covered to a greater or lesser extent. So it's really important that you be familiar with your own benefits, ask those questions. The provider themselves may be able to answer the questions, or they can refer you on to the right contact within the insurance company itself. So how do we get this started? How do you access palliative care services? As with hospice, it's important to just to know that it exists, to know that it's available to you, and to ask for it. You don't have to wait for someone else to bring up the possibility of accessing palliative care services. It may not be the right time, but there's never a wrong time to ask the question about whether or not this is something that you or your loved one may be eligible for now or in the future. I think sometimes because Alzheimer's disease and most other types of dementia don't produce physical symptoms in many people, symptoms of pain, I should say, right? We don't, those brain changes that Jean was describing a few minutes ago, we don't feel those, right? There isn't physical pain and suffering directly related to the presence of Alzheimer's disease or another type of dementia being in the brain. It's not to say that there aren't some physical symptoms associated with that, but for the most part, the pain, the suffering that is associated with dementia is of a non-physical nature, right? It's more related to a person's emotions, right? Living with anxiety in particular, very, very common in certain stages of the disease because of all of the confusion that is being caused by those brain changes. Behavioral changes, and in particular, behavioral disturbance. When somebody is very agitated, very combative, for example, these are conditions that make a person in any stage of dementia eligible for palliative care services. This is sort of a little known resource that is available to support you medically. So you can access a palliative care referral the same way you do any other type of specialty care. As I mentioned, many times palliative care services are initiated while a person is in a hospital, but that's simply because that's where we usually are when we're experiencing some type of acute pain. So you don't have to get the referral through a hospitalist or while the person is hospitalized. You can talk to primary care about a referral if you're in an HMO, or if you're a straight Medicare beneficiary recipient, you can self-refer to palliative care services, as well as with other types of specialty care. So just keep in mind, these services are provided in collaboration with one's primary care provider. Other types of specialists, they don't supersede or replace your primary care services. It's supplemental, as with other types of specialty care. So that's palliative care. And again, I've reminded you in the chat, and I see that some questions have been coming in. Please, if you've got questions about palliative care services that are still unaddressed, feel free, write them into the Q&A box, and we'll address those a little bit later. For now, I'm going to move on to the topic of hospice care and how it is different from palliative care services. So hospice care is different, but it also is focusing on pain, right? But hospice services in particular are designed to address the pain, the suffering, the comfort, the quality of life of a person who is living with a terminal illness. So it's significantly different from palliative care in that regard. A person becomes eligible to receive hospice services when they are in the stage of their illness where it could be reasonably expected that with the natural progression of this disease, whatever it is, Alzheimer's disease or any other type of disease, that their life expectancy could reasonably be expected to be 6 months or less. Of course, that is a guessing game, as Jean was describing, the variation of how long a person will live with symptoms related to dementia, or how long a person will be in the late stage of the disease is very hard to predict. But according to some established hospice standards, and I'll share those with you here in a moment, if a physician believes that this patient could reasonably be expected to die within 6 months, we call that sort of the window of eligibility for hospice. Hospice is also provided by an interdisciplinary team. It is really a type of palliative care, right? So palliative care is this big umbrella of all of the medical treatments that address pain. Hospice is a particular type, and it is a Medicare benefit. It's a little bit different in that it doesn't just work with your primary care provider. The hospice provider really becomes your primary source of medical and other types of support once you enroll in hospice. It is time limited. Unlike palliative care services, hospice care services, again, are designed to be provided at the end of life, but one can renew. So if you live longer than 6 months, and often people do, right? Because the hospice services themselves actually make the person function a little bit better. So life is sometimes extended through the provision of hospice services, not always, but sometimes. But that's not to say that, well, your 6 months are up, right, and you get discharged from hospice services. As long as the patient continues to meet the eligibility, the eligibility requirements that are set by Medicare for hospice services, or their insurer if it's not Medicare, the person can be renewed. So you go through what's called a recertification process after that 6-month time is up, and a person can be re-eligible to continue hospice services. You can also come on and off of hospice services. It's not an onerous process to be discharged from hospice and then to come back on as well, because the journey can be unpredictable. And sometimes at that 6-month point, the person no longer meets criteria, but then they will again in another month or two, for example. That's all possible. So things can be started and stopped as needed according to the waves of your particular disease progression. Hospice care does not end when the patient dies. There are a lot of supports that are available to family, to friends, to close members of a person's sort of circle and support system. And those bereavement supports, other services can be continued for up to 13 months after the person has passed away. And again, another one of those little known and little used benefits that we really want to make sure care partners in particular are aware of. And hospice care, like palliative care, can be provided just about anywhere. A hospice is sometimes a physical place. There are residential hospice facilities, homes, more medical institutions. We only have a handful of them here in San Diego County, but they are more common in other parts of the country. Hospice being a specific place where a person goes. But most hospice services, far and away, the majority of hospice care is provided in the person's home, whatever they call home, a private home, independent living, assisted living, memory care, a skilled nursing facility, or even while the person is hospitalized. There are some limits in some assisted living environments, residential care facilities for the elderly, may be limited in the number of residents they can have at any one time who are receiving hospice care. So there is sometimes the requirement that a community seek out a waiver, permission to bring hospice services in. But again, this is not an onerous process. Don't be afraid to ask for it. And when you're looking at residential care options, should this be a project for you now or in the future, this is a good question to be asking. How many hospice patients can you have in this community at a time? And what happens if I or my loved one need hospice care while they're living here? These are good things to know up front. But for the most part, we want you to know you can advocate for receiving hospice care just about wherever you are. So let's get into the nuts and bolts a little bit of what hospice care kind of looks like. There are, and much of this information, by the way, comes to us from the National Hospice and Palliative Care Organization, a great resource for detailed information on how hospice services work. You can connect to statewide organizations as well. We will refer you on to this organization and others at the end of the program for more information. But hospice care generally falls into one of these 4 levels of care. This is good to go into being aware of. When you enroll in hospice services, you don't necessarily have this whole team of people descending upon you and providing 24-hour support. In fact, that's usually not what happens. There's what's considered the routine level of care, where the primary case manager is making regular visits. You have access, of course, in all hospice care, you have 24-hour access by phone to your hospice provider, but there's not somebody there in the home every day, and certainly not 24 hours a day. It's more just sort of making sure that the person is stable, making regular visits, making sure everybody sort of got what they need, but it's not continuous. There's inpatient hospice services, as I mentioned before. Some hospices that have an inpatient unit will have the person primarily living at home, but they may move into the inpatient unit if their pain is very severe and cannot be managed well in the home environment. For the most part, this is a rare occurrence, and most hospices, again, don't have inpatient a place for inpatient care here in San Diego County. That is fairly rare. Continuous care is generally only provided on a very short-term basis. This is the type of hospice where the person is in a medical, their medical condition is unstable. This may happen when the person is actively dying. It may happen during the uptick of severity of symptoms because of illness or infection, for example. Continuous care is around the clock. There's somebody there at the bedside around the clock, but it is not something that's provided all the time in hospice. It is only provided on an as-needed basis, on a very temporary basis. And then there's also some respite services available through many hospices. So if you maybe need some intense services on a short-term basis, many hospices can be a part of a person's respite plan, if you will. So the benefits to accessing hospice services are legion. It's really hard to overstate how useful, how essential hospice care is to many people in the end stage of dementia and other types of terminal illness. It provides comfort. It gives really highly personalized attention, much more so than most of us can receive through our traditional primary care and other types of traditional healthcare services. And one of the main benefits, especially for people who live in care facilities, assisted living, or memory care environments, is that it keeps people from having to make these repeated trips to the hospital. Every time a person has an infection, sustains a fall, right? Even if there's no injury, the way that it works, if a person is not on hospice, they're going to go to the emergency department to be evaluated, to make sure that they're okay. This is a requirement of those communities. It's not them overreacting, right? They're following their own guidelines. However, if a patient is using hospice services, if they have this incident, right, there are fever spikes, they have an increase in the severity of pain or symptoms, they sustain a fall, for example, the hospice team can come in and evaluate that person, and it eliminates a lot of that back and forth to emergency rooms, observation status, admission status, and all of the sort of trauma and stress that goes along with that. So a lot of benefits there. The specifics of the services themselves, again, hospice is a type of palliative care. So in many cases, if the person is suffering from physical discomfort, the hospice services cover medications that help to manage pain and symptoms. Let me jump down a couple bullet points there and just say hospice services cover medications, treatments, therapies that are related to the person's terminal illness, not necessarily to all of the medical conditions that they have if there are numerous medical conditions. But for the most part, so a person is admitted under a primary diagnosis, and therefore all of the services that are prescribed and administered are related to that primary illness. But of course, all pain and all healthcare, the person's whole body, whole being is certainly being cared for and supported through hospice. There is 24-hour on-call service, as I mentioned. In-person visits, again, just depends on what level of care the person is at, but there are regular in-person visits by usually a nurse case manager, or it could be the social worker who is serving in the role of a case manager in some cases. There is social services support, there is chaplaincy, and there are volunteer services as well. Medical equipment, if a person would benefit from having something like a hospital bed that can be adjusted, that's got rails, durable medical equipment that would make life easier for them in the home or for their caregivers. Medical equipment is ordered by and paid for through the hospice provider. I talked a little bit about it, inpatient care versus continuous care that's in the home already. And this last point, spiritual care and volunteer services I mentioned before, bereavement and counseling services, so important for the person who is living with the terminal illness, if they can use them and if they would benefit from them, and also for care partners. Jean's going to talk a little bit about grief and bereavement again toward the end of our time here this morning. Just want to make sure that you know this is just about the easiest way there is to access really high quality bereavement and counseling services is by being enrolled in hospice care. Here we go. So who's on the team? There is a primary physician. This can be your regular primary care provider if that's your preference and if it's their preference. You have a conversation with them and say, I'm going on hospice. Will you continue to be my primary care provider? Not all physicians can or are willing to do this, but many physicians will. So have this conversation with your doctor early, if at all possible. Is this something you can and will be willing to do? If not, hospices always have a medical director, and that physician will become your primary sort of physician point of contact. There are nurses, there are licensed therapists, speech therapy, occupational therapy, and of course, physical therapy. These are not put in place in an attempt to help the person recover. These are put in place to help a person feel better, right? If it helps them feel comfortable, to feel more comfortable to receive a little bit of physical therapy services, for example. That's the goal there. It's not curative. It's symptom management. And then I mentioned social work services, chaplaincy, and again, the range of volunteer services that are available through hospices is really lovely. So hospice organizations, there are lots of them. I'm actually not sure of the number that we have here in San Diego County, but I do know that a moratorium was recently placed. No new hospice services can be opened right now because we sort of reached our limit. There are a lot of great hospice organizations here in this. They're certified, they're licensed by the specific state. And they're Medicare certified by the federal government, but we have state-specific hospice organizations. There are some non-Medicare certified providers for people who have other private insurances that they might accept, and there are also hospice services that can be paid for out of pocket. Those are less common, but they absolutely do exist. And the VA does have a hospice organization, but people who are in the VA can also access hospice services from other organizations. That's an important thing to be aware of. Your particular healthcare provider, let's say you are a patient at Scripps or Sharp, that's where you get all of your healthcare. Many of our really good local healthcare providers, those big systems have their own hospices. Kaiser is a great example of this. They have their own hospices, but you have choice with regard to what services you use. Your doctor may refer you to an internal provider of hospice services, and that may be the right choice for you for any number of reasons, but you do have a choice. So hospice services, again, are provided wherever the patient calls home. How is hospice paid for? Again, it's a Medicare benefit. So Medicare and most Medicaid programs, including ours here in California, Medi-Cal, as well as most private insurance providers for people who are not Medicare or Medicaid eligible, have a hospice benefit. That again pays for all of the care related to a person's terminal diagnosis. So some medications, services, other types of equipment may be necessary but not covered. Private insurance companies might require a co-payment. So I don't want to paint a picture here of hospice coming in, taking over all your healthcare and covering everything. That isn't quite how it works. The benefits are generous and it does provide for a lot. But not everything. Notably, do keep in mind that hospice care is medical care. It does not cover what are considered custodial or long-term care needs. So a person's rent, in a assisted living community, for example, is not covered by hospice. Food, meals, right? Those types of things are not covered through a hospice benefit. It is strictly the medical care and supportive services related, again, to that life-limiting illness. How do you access hospice care services? Again, don't wait for someone else to bring this up for a variety of reasons. Physicians often aren't the first person to bring up, have you considered hospice care services? There's discomfort, there's stigma in the medical community as well. It can be hard for a doctor to bring up the topic of hospice. Sometimes we have to do it, and that's okay. You can ask for that referral. If your physician is not bringing it up and or this isn't a conversation you can have, you can actually contact the hospice provider directly. They can connect with the doctor to seek out that referral. The process generally starts pretty quick. Care can generally take place within a couple of days. There will be an initial admissions visit scheduled first to describe the range of hospice services that are available and to do all that sort of enrollment paperwork that's required. There is generally a nursing visit, happens pretty early in the process. And then services will be provided as you go along according to the care plan, what it is that this particular person and the members of their support system need most. Hospice eligibility criteria for late stage dementia. I like to go through this. This can be sort of an unpleasant topic to think about and to talk about, but I think as with many things about Alzheimer's disease and other progressive types of dementia, it's important that we talk about it, that we sort of destigmatize those symptoms and be willing to think ahead and talk about them. But it's also just sort of a commonly misunderstood illness, again, because there isn't, as with cancer, where there are tumors, where there is physical pain, right? Other types of terminal illness, where there's something more concrete, if you will. It's hard for people to kind of wrap their head around the idea of dementia being a hospice eligible condition, but it absolutely is. So a person meets criteria for admission to hospice if they are living with late stage symptoms of dementia that include the following. These are pretty broadly, generally worded, I think, by design. If the person is unable to complete their activities of daily living without assistance, and unable to communicate meaningfully. There are actually some guidelines for what that means. Unable to communicate meaningfully means having a very limited vocabulary, really only speaking a few words or sounds. This is something they will sort of measure, if you will, in kind of an informal way. Through interaction with the patient, of course. Intercurrent illnesses associated with advanced dementia. This could be having a lot of infections. Again, this is helpful for people who are experiencing a lot of hospital admissions related to urinary tract infections, for example, pneumonia, other types of respiratory illness, other types of illnesses that aren't, a urinary tract infection doesn't come directly, it's not a brain change that produces a urinary tract infection, but all of the circumstances that Jean was describing as those brain changes are happening result in a person being incontinent, maybe not taking in hydration the way that they need to, not having good nutritional status, right? Not having good bowel or bladder hygiene or personal hygiene abilities. All of those things taken together result in the person having a lot of urinary tract infections. That's what we mean when we say intercurrent illnesses associated with the advanced dementia. If a person has that impaired nutritional status, they're not able to eat normally and they're losing a lot of weight. That's really what that refers to. If the person has lost, I think that the number is something around 11% of their body weight within a 6-month period or so. That is a trigger for hospice eligibility. Or if they have late stage dementia and other comorbidities, other illnesses that are chronic, that are significantly impairing their health and functionality. This is kind of that broader point of the eligibility criteria. So that is to say, the person is reasonably within this last 6 months of their life meets one or more of these criteria, then the person is probably eligible to receive hospice care. How do you choose a hospice program? We do have a checklist for this that we can send out to you if you want to see more examples of this, but I've just sort of picked and chosen a few of the key questions that you might ask when selecting a hospice program. What services do you provide for the patient, but also to the family and to the care partners? What is the role of the attending physician at the hospice? Or if it's going to be my own primary care provider, how will that work? Right? What is the hospice going to do to keep me or my loved one comfortable? What do we do after hours? If there is an emergency, a sudden need, or a change in the person's status, what's your policy? Again, they're all available 24 hours, but they all have their own policies and procedures. Is inpatient care available? And if so, how does that work? How and when do we access it? This particular hospice, are there specific facilities where you do or do not provide services? This would be something you want to be aware of, and just clarify expectations. How long could we expect if we decide to go with your hospice? What can we expect with regard to admission, enrollment, and getting services in place? So, and just an example of some of the questions you might ask when you're exploring your hospice options. So in summary, just showing you this sort of image again, I hope that these last few minutes have helped explain the ins and outs, the differences between hospice services and palliative services, but also helped you see sort of where they overlap as well.
Thanks, Amy. I am going to dive right into advanced care planning here. And, at its very basic, what is advanced care planning? Well, it's the discussion and the planning and the preparation for deciding what types of emergency medical or end of life care treatments that a person wants. And, to sound, I guess, a little bit overstating things here, but please really focus on the word advance. And we need to do these things well ahead of time. And really, I'm taking Amy's words here, and that really everybody over the age of 18 needs to have some kind of advanced care planning discussions and decision-making and plans in place, paperwork that is in place. So what do we need to know about advanced care planning? Well, let me say, first of all, that I'm no legal expert. I don't think Amy is either. We do have a legal and financial basics webinar that you can watch in our webinar library. And additionally, we will have live webinars on those topic areas coming up in the future. These are webinars that are taught by elder law attorneys and estate planning attorneys. So these are really the experts to talk to with regards to advanced care planning. But a brief review of the key documents that are a part of this type of planning is, first of all, is the power of attorney. And there's two areas where power of attorney is important. And one is health care decisions with regards to the type of care and the emergency medical treatment we want. And then the financial, managing the assets and the finances of a person. Generally speaking, the elder law attorneys that we talk to are suggesting that not be the same person who is in both those roles, but rather a different person who's the power of attorney for healthcare decisions, and another person who is power of attorney for the financial and asset management decisions. So when you're appointing a power of attorney, you are appointing this person to be your decision maker in the event that whatever the circumstances, dementia or other things that are going on, that you are unable to be your own decision maker. So that's when your power of attorney steps in. The advanced healthcare director is also sometimes called the living will. This is the actual document that you complete and that is witnessed and signed, that is giving your specific instructions for what you either want done or don't want done come the end of life. The HIPAA forms and other institution-specific waivers. HIPAA, of course, is referring to the Health Insurance Portability and Accountability Act. And it is, along with some other institution-specific waivers, some of the legal documents that helps to protect our health information. And so having advanced healthcare directives is important. And you also want to check with, probably through your doctor's office to see if there are some waivers that are specific to the medical group or the institution that you work with. So for example, Scripps, Sharp, Kaiser, all of these entities may have their own HIPAA waivers or other specific waivers that they would like you to have on file. So do inquire about those things. The physician orders for life-sustaining treatment is the POLST form. We call it the POLST because that's the acronym here, physician orders for life-sustaining treatment. It's almost always on a very bright pink paper. And this is just kind of universally recognized here, certainly in the United States. This is just as it says, it's a physician's order. So you can talk about this with your doctor. You actually, after you've made decisions, you would actually complete this particular form, this order, together with your doctor. And it is legally binding, and we'll talk a little bit more about that in a couple of slides here. And then I just want to point out, these are some tools that can be really helpful for having these important discussions and making decisions from them. So prepareforyourcare.org, visit that website, and it will take you kind of the decision-making process for an advanced healthcare directive, step by step, and it has some little video stories that are there as well too, to hopefully spark further discussion for you. 5 Wishes is another document that you can download through this website. And it is, again, a kind of a step-by-step document that is quite easy to use and uses kind of everyday language, so you can come to some discussion and decisions about what your 5 wishes are for your end of life. You're not limited to 5, there can be more. Go Wish is kind of a neat card, I'll use the word loosely here, game. It is intended to be something that you use with family and friends, the people who are important to you, the people who are in your direct support network, to again spur this type of discussion of what is important to each of us with regards to how we want to be treated and taken care of at end of life. So we do want to address some of those important healthcare decisions that you can explore with some of those resources that I've just talked about. And so CPR, of course, is, I think we're all familiar with that, is, when a person's heart stops beating and we are using the CPR procedures, extreme pressure on the chest to manually stimulate the heart. And this is commonly used, obviously, in health care settings and also just by Good Samaritans out there in the community. Most of us have probably received some type of training and or information about CPR and how to administer it. How do we make the decision about, do we want CPR done to us or to our person, or not? Well, some just basic kind of guidelines is that CPR is more likely to be helpful to a person who is healthy and active, and for whatever reason, their heart has stopped. And it is most likely to be helpful to somebody who have CPR starting up really almost immediately after, or very quickly after the heart has stopped beating. There are people who have a type of heartbeat, a type of arrhythmia, you know, where the heart is out of rhythm, who respond to some of those electrical shock treatments that we may be aware of that go on. And there are some people who are not helped by those particular paddles that can be used. And we see them, those emergency systems more available in the community now, to be used again by Good Samaritans. There's specific instruction with regards to those. But again, CPR is helpful to people in a fairly limited scope, I guess is what I would say. So who is less likely to be helped by CPR? Well, people with those really serious or terminal illnesses, such as advanced dementia. People who are older, weaker, or very frail, because there is, you know, a lot, I mean, the pressure that's being put on the breastplate here to manually stimulate the heart is, I guess I would say, extreme and severe. So older, frailer people, you know, that doesn't always go well for some of those folks. And, you know, when they have already now other health conditions as well as advanced dementia. Which is not to say you don't consider it. Again, everybody, we have individual viewpoints and opinions on these things. This is important, why we need to have those discussions well ahead of time to determine what's going on and what people want to have happen. With regards to feeding tubes, and I'm also going to say artificial hydration, IV hydration, again, more likely to help people who were really mostly healthy before the illness or whatever it was occurred, and who really have the physical strength to recover. And for those who will likely only need the intervention for a short time, I'm also going to include the ventilator in this description, because, you know, I think some of the ways we can envision where this has been particularly helpful is to a lot of the people who did in fact end up hospitalized with COVID and required some of these things, in particular ventilators, and they were able to recover. These were healthcare decisions that were made that were very helpful for them. People who are less likely to benefit from these types of interventions are, once again, those with serious illnesses, such as advanced cancer or advanced dementia. And again, people who are older, weaker, or frail. Use of antibiotics and hospitalizations is and can be a part of some of these other interventions that are going on. And it just needs to be part of the discussion. If you're talking about you don't want CPR, if I make a decision, I don't want CPR done if I'm in an advanced stage of illness, then it's probably a good thing for me to talk about not having feeding tubes or IV hydration, or potentially use of antibiotics as well too. So again, the discussions need to be had. Here's that POLST form, the physician order for life-sustaining treatment. And you see it's pink, and it is a really bright pink. This is a voluntary form. It is intended for those with a serious illness or advanced frailty. This is not like an advanced directive that we would complete when we are healthy and active. This is for a time where, you know, we've got some kind of serious illness going on. And by the way, it also doesn't replace an advanced directive. It is signed by the decision maker and physician, also can be signed by a nurse practitioner or a physician assistant. This is a standing medical order, so it doesn't expire and it doesn't go away. And it is transferable. It follows you. If you have at this time or plan very shortly to have a post form completed, what we suggest you do is, you know, of course, you'll have a copy of that in your medical file with your doctor's office, but make sure you make these bright pink copies of that post form to have on your fridge in the event that something happens to you at home and you or somebody else calls 911 for assistance. Make sure your decision makers, your power of attorneys and others have copies of your post form. And what happens with that is if you are to have an incident at home where 911 is called and first responders arrive, you know, ambulance folks, if you've got that post form right there, obvious for them to see on your fridge, and if in that post form you're saying you don't want CPR, that is a physician's order, and so they will follow that order. This post form can be used in any setting. So with regards to death care, I mean, take a deep breath again for me. And then just think about what is the support that you need. Looking ahead at the time of death. And maybe start jotting down some notes, make a list. What will you need to do at the time of death? Obviously, contact key family, friends, and supports. If there's specific instruction for organ donation or brain donation or donating bodies for medical science, whatever it is that's going to be done with the body, you will need to follow those instructions. And that will mean selecting or contacting the funeral home or service that you're going to use. And it's, again, we're talking about preparing for a good end. So think about these things ahead of time. And you can, as many people do, is make arrangements ahead of time with specific funeral homes or services for the type of disposition of their remains that they wish to have. Allowing the person, the body, to remain at home for some time or be moved to another home. That can be done, you know, at the time of death. Bodies don't need to be rushed away necessarily. And, you know, think about the rituals, the grief and death rituals that may help you. And, or maybe something that you would like to have happen in that time. And so, yeah, I think I mentioned yesterday when my father-in-law died and we got to the house. We weren't there at the time of his death, but we got to the house and he was on the floor and my mother-in-law and I she was on one side of him and I was on the other. We were on the floor. And one of the things that became a ritual for her at that time was he had a favorite blanket. And she wrapped him up in the blanket and kind of tucked him in, as it were, and that made her feel better. And so I went along with it as well too. So that was our little ritual that we had. So of course, after a death, and let me just say, after a death does not mean it has to be done right immediately. But after a death, an attorneys, banks, insurance providers, for sure, Social Security, and others do need to be advised of the death. And you will need some documents for that, the death certificate, and have maybe the funeral director or the health department make some copies of it, or you can yourself, so that you've got several copies, just so you can distribute as is needed. It's good if you can have much of this paperwork together already. You'll get the death certificate after death, but Social Security cards, marriage and birth certificates, discharge papers from the military, for sure, wills or trusts, any sort of lists of assets and finances, and even a recent income tax return. All of these are important documents to have handy as you then go through the steps after a death. You may not be aware there are such things as death midwives and doulas. So just as there are midwives and doulas as we come into life, we have midwives and doulas to help us at the end of life. And the goal of these particular specialists is to help make dying less painful and more dignified. And the scope of what they can do, this is not medical intervention. So, but these folks can attend to both kind of the spiritual matters and concerns, as well as the practical things. And they can help coordinate both ahead of time, during, and after death activities. So these are professionals who can kind of be our guides through the death process. And I must say, I think they're very good at what they do, and very committed and passionate about the work they do. I think they can be a great resource to families. If you've been through this experience before, even knowing that your person is dying, and so you are planning and preparing for death, that it still sometimes you don't think so well. And so it is good, I think, for many people, wouldn't be for everyone, but for many people, to have that guide with you to help you with the bits and pieces of this experience that are challenging and that you may not always be thinking 100% on. So death doulas. Medical aid in dying. This is something that does come up in regular discussions at Alzheimer's San Diego. We do have an End of Life Options Act here in California. And at this time, people with late stage dementia are not eligible for it because it requires capacity, decisional capacity, for people who choose to look at medical aid in dying, who want to be in charge of that, and but they have to be able to have, oops, I'm sorry about that. That was my computer making some noise. They have to be able to have capacity to make the request for the lethal self-administered medication. And they also have to have the capacity to administer it to themselves. And so people with dementia don't meet those requirements. At this time, there are some other countries in the world that are looking at and making moves towards, a couple of them have already made a move towards the idea of having an advance directive that results in a medical aid in dying that you complete when you are competent, but that can take place when you lose decisional capacity. So you make the decision when you know, early on, before the dementia has really impacted your executive function. And then that directive is in place for later on when you wish to be, have the euthanasia, the physician-assisted suicide take place. So we've gone through lots of information here. We're going to pause very briefly for some questions here. We don't have a lot of time and still have a few more things to go through, but let's just stop for a moment and see what we have. So what have we got? Ellen and Amy, are you with us here too?
Yep, I'm here.
So the first question is, does hospice provide, or how do they provide emotional treatment for the person who is in the process of passing, or, you know, even before that, but while someone's under hospice care, how do they provide emotional treatment support for the individual?
I have a go at that.
Sure. Yes.
Are you there?
Yes. Did you say you wanted to have a go at that?
No, I'm sorry. You may, I said, would you like to have a go at that?
Sorry, everyone. We're having some connectivity issues here today. I apologize. Sure, happy to cover that. As I mentioned, the hospice care is provided by an interdisciplinary team that will frequently include the services of a social worker. So the social worker may be able to provide direct psychosocial support to the patient, depending upon their communication capacity, their ability, or they may be able to refer them out to psychiatric support, psychological support if that's needed. So there's no one way that happens. It's just a matter of what that individual patient needs and would be able to benefit from.
Good.
Perfect.
I'll say, let's take one more question here, Ellen.
Okay. So, well, somebody just asked, oh, okay, let me figure out the three. So would you please clarify the relationship between a primary care doctor and a hospice doctor, and the best way to communication flow, and how to be a good advocate for when you're used to working, when you have that relationship with the primary, but then there doesn't seem to be good communication. Who should you go to as the caregiver first? Hospice, the primary care? Could you clarify that just a little bit?
Well, I think it depends upon whether or not your regular, who is your hospice doctor. Somebody will be designated as the primary physician for the hospice services, and that is your point of contact. So as I mentioned before, that may be your primary care physician. The overseeing of the hospice care may be done by your own primary care doctor, in which case your point of contact doesn't change. But if you've made the decision that the hospice's medical director is going to be the hospice doctor, then that's your point of contact. So it just depends on how it was set up from the beginning. Do know that during the admissions process, this is what the hospice talks you through. What are your wishes? What are the possibilities? And then they set up sort of the points of contact. But the point about being a good self-advocate applies as much with hospice care as with any other type of medical care. Ask questions until you get answers. Keep asking around if you're not finding what you need. But the beauty of hospice services is that in addition to the doctor, you have your case manager, right? That nurse that's making regular visits that you're going to have an established relationship with. So for many people, that's actually the easiest primary point of contact rather than the physician directly.
That's great. Thank you. I'm going to sneak in one more question, Jean. The midwife, the doula, does hospice provide those, or where can someone find one?
To my knowledge, hospice does not provide doulas at this time,
Right.
but I would not be surprised if the doula doesn't become part of the hospice team, should you wish to have a doula at some point in the future, but not at this time. There is a national organization that is called National End of Life Doula Alliance. And so that would be something to throw in your browser bar to find out more about doulas and who doulas are here in San Diego County. And, for more specific questions with regards to doulas, and certainly other questions that we're not able to get to you, get answered for you today, I see Ellen has just put in the chat our follow-up forms. So please just complete those forms and we'll get back with you with more information.
Thank you very much.
Okay, I think we're going to continue on here because we are getting close with grief and bereavement. So again, we're just kind of going back to that vision of the water, floating in the water. And just for definitions, bereavement is the period of time that is occurring after loss, when grief and mourning occur. And grief is our own personal reaction to that loss. And clearly it's unique in the ways we experience it and in the feelings that come from it and how long it goes on. There is no one right or wrong way for grief and bereavement to go for us. Your grief can occur at every stage of the disease. I'm jumping down to ambiguous loss, which we've talked about a few times, where we've got some grieving and some sense of loss going on when the person has not died. They are still here, but they are also in many ways absent. Grief is really non-linear, and I would absolutely agree with that. It doesn't follow this particular timeline. And, kind of some of the old adages that you might have heard where, oh, things will get better with time. Grief gets better with time. And for some people it doesn't. And, it depends on your experience, and it depends on, how you term your grief. I feel that I still grieve the loss of my mom over 20 years ago. Now, do I have that sharp sense of grief I had after she died? No, but there's still sadness and I still miss her. And that is my grief for her. So there is no particular timeline. It is influenced by your relationship that you have had with the person, how you are doing in terms of your own well-being. And of course, there are cultural and spiritual beliefs that change how we experience grief. Don't forget that they have grief too, the people who are in the late stages of the disease. And in fact, grief is going on at all stages in different ways and means. Not for all people, but for many people. And again, it's not linear. And again, it is influenced by all those things that make each of us unique. Addressing fear and anxiety, I think, is pretty important during this whole time of late stage. So think about the items that provide comfort. Is it special blankets, or for me, I always say it's a golden retriever. Think about breathing together, spiritual support, whatever that looks like for you. Maybe it is more spiritual and religious support from a specific, say, for example, church. And maybe it is something that is broader and has different meaning for you, but is still spiritual support. And of course, there is the medical intervention that can help with fear and anxiety if it's really getting enough to be affecting kind of the moment-to-moment quality of life at that time. So coping with grief, as we've said, there's no universal experience or timeline. Release yourself of expectations, both yours and others. As I said, do your best to come into this time of end stage of life, either as a care partner and a support, or at such time, it maybe you yourself just try to keep your mind and your heart open to the experience. Acknowledge the loss, the community loss, as well as the individual losses. Look at the supports you need and know where to turn to if the grief continues to be really persistent or complex. And Amy's going to wrap up here with us with resources for more information and support.
I will. Thank you, Jean. May I have the remote again? And,
You may.
everyone, I'll just say I'm going to go through these resources fairly quickly in the name of time, but also because you are going to receive an email shortly from us that will have all of these slides and all of these resources in it. So for more information about the nuts and bolts, the ins and outs of how hospice and palliative care services work, I referred to you earlier, the NHPCO, the National Hospice and Palliative Care Organization, and you see here our state-specific organization. The California Hospice and Palliative Care Association has a lot of great answers to frequently asked questions. Medicare, the Centers for Medicare and Medicaid Services, because hospices are covered by Medicare, they sort of regulate and oversee that. There's a lot of good information on the Medicare.gov website specific to hospice. And for information about these end of life planning resources that Jean was talking about, the Coalition for Compassionate Care of California is a terrific resource. Lots of state-specific information, information about the post form, but many other really important topics, including late-stage dementia considerations. Okay, so here in San Diego County, I want to make sure that you know that we at Alzheimer's San Diego hope to be a resource to you. We can provide you with information, referrals, and information about all of these different types of local and other resources, advanced care planning, information about the donation of organs, or specifically brain donation is something a lot of people with Alzheimer's disease and their care partners are interested in learning about. We do have some locations here in San Diego County who accept brain donation. Of course, counseling resources, end of life care resources, lists of the local hospice providers, and again, considerations and questions you might explore when looking at your options. You need a connection to a primary care provider, or a specialist with good dementia experience and expertise. We maintain lists of local providers, as well as a checklist regarding sort of the steps, what needs to be done right after a death. We have a tip sheet that we can send out. A few local things I want to make sure that I mention to you specifically. First, the Death Cafe. If you're not familiar with Death Cafe, this is an international movement, and we have several local Death Cafes. I believe they're all currently meeting virtually, but traditionally they are in-person communities of support just for talking about death and dying, not necessarily, I mean, not related to dementia, not related to any particular illness. It is a place to go and ask questions. They're generally just volunteer facilitated. You can just get feedback, get support, express fear, discomfort, whatever it might be, sort of a social support community for talking about death. A really terrific resource. And we have a robust Death Cafe program here in San Diego County. The Hemlock Society of San Diego, also a very active organization. Hemlock Society provides a lot of information, support, resources, and practical information for people who are looking for it about medical aid in dying. Hemlock Society is the sort of local branch of something called the Final Exit Network, which gives information about sort of self-administered end-of-life options. So Hemlock Society is a terrific resource for people who want to explore the possibilities for having control over one's own death. As Jean described, the current laws around that are very limiting here in California, but a lot of people have questions about it. So I like to make sure that we tell you about Hemlock Society, a terrific local source of information that's hard to really get anywhere else. We also have something called the San Diego Coalition for Improving End-of-Life Care. This is a coalition of providers of hospice and palliative care services, other healthcare providers, social service providers who support people at the end of their life or those who are exploring their options for the future. So don't hesitate to reach out to any of those resources. And again, please consider us a part of your support system when it comes to preparing for a good end for yourself or for someone that you're caring for. You see here, we offer a variety of supports and services for people who are impacted by dementia. In any type of dementia and in any capacity. We are here to help, and all of our services are always provided at no cost. So if you need more information about any of our direct services, things like talking with one of our clinical care coaches, if you need to find a support group, if you would like to explore your respite options, any of those types of services, please fill out the form that Ellen has been sending out in the chat. I see that it just went out again. Thank you. We can arrange for a member of our team to reach out and get you what you need. And the fact is, all of this that we've been talking about here today, you may not even have a specific question, right? You just may need to sort of talk about what's coming up for you, what you're worrying about, what you're thinking about now or for the future. Our dementia experts, our clinical care coaches are here to support you in those ways as well. You just sort of need to vent or just to talk, even if you don't have a specific question. We're here to help with that as well. Okay, so for more information outside of reaching out directly to us, you can visit our website. But you can at any time call, email, live chat us from the homepage of our website, or again, fill out that request form that Ellen has been putting out in the chat. We will follow up with you directly. We do have a few upcoming education programs we just want to make sure you're aware of. Next Wednesday morning, we will be facilitating a Spanish language webinar, a broad overview of various topics related to Alzheimer's disease, related dementias, risk factors, tips for brain health, and resources for getting more information for getting more resources and support. That will be taught by our colleague in the education program here, Nelly Hernandez. So it will be taught in Spanish via Zoom webinar. So if you know anyone who would benefit from that, please spread the word. We'll be doing a program on communication skills later that week in partnership with our friends at Elder Help. And then in November, a program on the subject of maintaining good brain health. And this is a topic of importance for everyone, care partners and people living with dementia alike. So information on all those programs and much more, of course, is available on our website. So we really appreciate all of you coming today, thinking and talking about these difficult topics with us. sharing the resources that you've used. I've loved seeing information being shared in the chat. Thank you for that, as well as asking really good questions. Thank you, Ellen, for answering a lot of those really good questions and for being a good support to us here during the program. Thank you, Lindsay, for helping out with any technical difficulty. I'm sorry you couldn't help me with my own technical difficulties today. I apologize, everyone, for any inconveniences there. We will be following up with an email later today with these slides, as well as some supplemental information, and a recording will be available in our webinar library soon. So thank you very much. Thanks for coming. Thank you, Jean, Ellen, and all of you.
No problem. Take care, folks. We'll see you again.